All right, so in the interest of keeping this on schedule so we can have a little bit of Q&A time at the end, I'm going to go ahead and start. Today we're going to be talking about disabled parents in the NICU, and we have 3 amazing speakers. I'm so happy they're on board today. My name is Nicole Lamerson, and I'm a research associate at the Lurie Institute for Disability Policy at Brandeis. And I'm working under two grants. We have our National Research Center for Parents with Disabilities and our National Center for Pregnancy and Disability. I'm a disabled parent. I'm a former NICU mom of a 33-and-a-half-weeker. I'm also a NICU baby. And I wear a lot of different hats in the NICU space, but in addition to being here at Brandeis, I also do some statewide quality improvement, specifically around family engagement. And I think that's especially pertinent for what we're going to be talking about today. And my email is below. Please feel free to reach out. Our funder is NIDLR, the National Institute on Disability, Independent Living, and Research and Rehabilitation Research. We're working under 2 grants from them. And of course, our views expressed on this webinar are ours, not necessarily our funder. Real quick housekeeping. If you need closed captioning, we're doing automated Zoom captioning, and there's a button down below. And then you can see where the Q&A button is also down below. And we also have ASL interpretation. And for ASL, if you'd like to make the speakers box bigger, so the interpreter's box bigger so that you can see better, just slide this bar where you see the bright red arrow. Okay, so our learning objectives today are to understand the basic demographics about disabled parents in the US, and we're going to learn from some challenges and successes of 2 parents with disabilities who had premature infants in the NICU. And finally, we're going to talk a bit about systemic bias and implicit bias in the healthcare setting, which includes the NICU, and how that can impact patient care and family engagement in the NICU. So just a few quick statistics to give you the lay of the land of what disabled parents look like in the United States. About 1 in 10 children in the US have a parent with a disability, and there are between 4.1 and 7.4 million disabled parents in the US. This is a wide figure, and it's all inclusive of many disabilities, including physical disabilities, intellectual and developmental disabilities, sensory impairment, psychiatric disabilities, mental health disabilities, and disabled people tend to have children at the same rate as non-disabled people. This one I think is especially pertinent for this audience today. Women with intellectual and developmental disabilities, we know a little bit about their pregnancy outcomes, and they're more likely to have adverse birth outcomes, such as low birth weight, premature birth, and stillbirth. And then parents with disabilities often find themselves interfacing with the child welfare system. They're more likely to have their parental rights terminated, and they are often reported to child welfare agencies in the absence of abuse or neglect. So these parents really are facing an uphill climb in some cases, and I'm really excited to talk to you further about that today and listen to our panelists. One thing I did want to add here before we begin is I think a lot of people sometimes wonder who might be the best supports for these parents. And I have found that occupational therapists and early intervention professionals can be a great support. And we can talk about that more during the Q&A. But right now, I'm going to hand this over to Kristie Lewis. Kristie is from Rangeley, Colorado, and she is a former NICU parent who has a physical disability. She has a 7-year-old son and a 1-year-old daughter. Kristie has an associate's degree in early childhood education and experience as a caregiver for others with disabilities. All right, I'll let you take it away, Kristie.
Hi, so as Nicole said, my name is Kristie, and I live in Colorado with my family. My daughter, who's 1, is the child that was born prematurely. Oh, before I forget, I'm a white woman with brown hair and brown eyes, wearing a green and white top, just for anyone that might need a description. And my pronouns are she and her. Anyway, so my daughter was born prematurely because I had preeclampsia. And there were definitely some good things about our experience, but it was traumatic being in the NICU. So I hope you won't mind, but I've actually written down what I would like to say. It can be really emotional for me. And if you notice me kind of like jumping a little bit, that's normal for my disability. So, don't worry about it. Um, I'll begin reading what I wrote. I was as scared as any parent might be, but on top of the usual questions, I couldn't help but focus on something more specific. I wondered whether I would have access to my daughter, and if I did, I feared being misjudged as unable to care for her. Having spastic quadriplegic cerebral palsy, I knew that I would probably be questioned about my ability to care for a newborn, especially one who was 6 weeks premature. I feared that the visible effects of my disability, combined with stress and an environment that was not designed with the needs of someone like me in mind, I'm unable to walk and my motor skills aren't the greatest, would give staff the wrong impression. I thought we would do okay though, because I had a plan. When I reached out to Nicole for support, I actually told her that up until the moment where I got really scared, I thought I had done everything right. I remember telling my partner, Steven, we were waiting for the social worker, and I said, I just have to get ahead of this. If I tell them about us, if I point out that our house is as accessible as we can make it, but the hospital isn't, if they know that we have an older child that I took care of by myself, that I have a degree in early development, they'll stop worrying. I cried a little bit as I told the social worker these same things, including that I had spent the last year caring for my godson while his parents worked. He was only just over 1 by the time my daughter was born. I remember saying, what you will see in terms of Stephen helping me here does not paint an accurate picture of what I need at home. I know that I can take care of her independently, and I don't want to be treated differently than other parents. Even in the midst of my emotional upheaval, I knew that this was the best thing I could do. I told myself that the less surprise there was surrounding my disability, the less doubt I would encounter. I was sure that I was doing everything right. There were definitely good things that happened as a result of my speaking up. The social worker arranged for a special bassinet to be brought into the NICU that would make it easier for me to handle the baby while seated. You can see in the picture on my slide that I even gave my daughter baths with the tub securely in the bassinet. It's worth noting that the labor and delivery floor told me the hospital had the Halo bassinet to be used by parents recovering from C-sections, but several L&D nurses told me they'd never seen it used. In fact, one nurse that I did not know even visited us briefly at the NICU because she was curious. She said she'd heard they were letting me use it, and even though she floated between L&D and NICU, she had never seen it used before. I also got support from the occupational therapist assigned to monitor my daughter's progress toward feeding independently. She tried to find support equipment she often used in her work with disabled children and adults that could be applied to breastfeeding. I was thrilled at that point that the worst images in my head did not seem to be playing out. Even so, there were things that I just couldn't shake. A gut instinct told me that it was discrimination. There were a lot of comments suggesting that everyone suspected Stephen would be home all day, even though we told them over and over again that he worked full time and I was the one home with our older child. One nurse in particular never seemed anything but doubtful as I tried to breastfeed, even though she also questioned if I could do paste feeding with a bottle. I'll never forget how shaken I felt as I overheard her take the lactation consultant aside and whisper, "Do you see how much he's helping her position?" This was especially distressing to me as the baby was healthy but struggling to feed consistently by mouth. They told us regularly that we would be home when she was eating well, and I wondered what might happen if they didn't think I could feed her at home. The partners of able bodied parents who chest feed are praised for helping, but for us, it was just evidence that I would be unsuccessful alone. I also remember the nurse that I mentioned. One day she began, as I was breastfeeding, she said, um, "So are you only going to breastfeed when Steven's not working?" And then she kind of stopped mid sentence and said, "Oh no, your mom will be there all day whenever he's not, right?" And I said, "No, it will be me, but I know what to do when I'm by myself." And she just seemed really skeptical that I would be able to figure it out even as the baby got bigger and stronger. One day the OT came in and she had been really supportive, but she was asking me a lot of questions about the specifics of how I handle babies at home. And these were all things that I had already explained, like that we had an accessible crib set up and that I typically sat on the floor with young babies because I'm more stable that way. I became very upset when she suggested that perhaps she could mimic our setup at home there at the hospital and have me get down onto the floor to demonstrate how I did things. She even mentioned recording me. I was terrified that this was a test I had to pass in order to be allowed to bring the baby home. She said her intention was only to see what other support could be offered, but I found this frustrating as I had explained many times why my way worked best for me and that I had a lot of experience with babies who weren't my own, as well as my son, who at that point was in kindergarten. While my daughter was in the NICU, I was referred for a power chair. While I appreciated the support, I was somewhat frustrated. I tried to explain that insurance takes a long time, and even if I already had the chair, I wouldn't immediately be able to use it to care for my daughter. Using the chair would require learning new ways of doing everything, not to mention reworking the setup of my home. It took 6 months for the chair to arrive to us. And that's after the process of going to a doctor, having a doctor and a PT approve it, having them write up a report about what I needed, and then having a wheelchair specialist actually fit me for the chair. It's a long process. It's been 8 months since I got the chair, and I'm still figuring out how my house needs to be and relearning how to do tasks on my own. I don't want to make anyone feel like they shouldn't offer assistive technology and the like, but when you do, I think you should recognize that disabled people are experts in how they accommodate their disability in order to function. To the nurses at the NICU, many of them thought that giving me a power chair would be a quick fix, but I knew it was more complex than that. And it's important to note that this wasn't me saying, "I don't know how to do these tasks." It was me saying, "Here's exactly how I've done it successfully with multiple babies," and them saying a power chair would work better, even when I protested. Um, Within a few days of that conversation that I mentioned with the OT about getting down on the floor and demonstrating, my mother had to replace my partner so that he could go back to work in our hometown a couple of hours from the NICU. Many comments were made by multiple staff members about how lucky I was that grandma would handle everything. By this point, I had stopped trying to argue that she would not need to do everything for me. Within less than 3 days of my mom's arrival, we were sent home. I understand that everyone, disabled or not, benefits from a solid support system, but the implication that my mom, who actually deals with invisible disabilities herself that they couldn't tell, is my children's primary caregiver and not me was really unfair and harmful. I hope it's clear in listening to me that I do not believe anyone wanted to harm us or separate us. I knew, though, that I could be seen as incapable, even though I was not. As I said to the OT the day she suggested a demonstration, disabled people who are just as good of parents as I am lose their children every day. Social workers do not always have experience with disabled people, and these things can have a way of snowballing. I don't want someone to misunderstand me and take my baby. I could see that the OT was taken aback at my strong reaction, but I knew, as do many other disabled parents, that Colorado is one of 37 states that lists disability of a parent as grounds for removal of a child from their home. I wish I could tell you I was poised and self assured in that moment, but honestly, I was sobbing. I mean, like, I was hysterical. It was often hard for me to be certain that I was not being too sensitive about my disability and my parenting. A couple of months after we were discharged, my daughter had a follow up appointment with the OT from the NICU. After I confirmed that we were doing well at home, the OT said something like, "I told them you would be okay." I asked her if that meant that some staff thought I wouldn't manage. She seemed hesitant, but admitted there were questions. I had to do some convincing, but I knew you'd be fine. Personally, if doctors and nurses had concerns about how things would go once we were released from the hospital, I would have preferred to be included in the conversation. Before we were discharged, I had reached out to my pediatrician. I knew she was well known at the hospital where our NICU was located, and she had been a great resource since the birth of our older son. She told me in the past that she would be willing to speak up on my behalf if anyone was suggesting that my children might be at risk due to my cerebral palsy. I explained to her how uneasy I felt, and she made a call. I do not know the details of that conversation. I only know that my partner and I feel that it was a combination of my decision to give up breastfeeding, the appearance of my mother, and my doctor's call that contributed to my daughter's discharge. While I understand that NICU staff want what's best for babies, I feel I had to work harder to prove myself than NICU parents without disabilities. This did not necessarily benefit me nor my daughter. I do feel that my confidence as a mother was greatly impacted by my NICU experience. I even suffered panic attacks after we came home. I find it ironic when I think about how we were questioned very little with the birth of our first child. At that time, we had virtually no support system. We were almost 7 years younger without prior parenting experience, and I did not yet have any degree. All of those circumstances had improved in our favor by the time my daughter was born. My partner made more money, and we had become homeowners since having our son. Yet I felt more doubt in the NICU as a second time mother than I did with my first child's full term birth. This would not have been true were it not for my disability. Overall, I had protective factors at play, such as the perceived able bodiedness of my partner and mother, and I came home safely with my family intact. I am, however, acutely aware that many families are not so lucky, And that is why I wanted to tell my story here today. Thank you.
Thank you so much, Kristie. I always tear up when I hear your story, and today is no different. Thank you so much for sharing. We're going to move on to our second speaker now, Patrick Coakley. Patrick Coakley is a former NICU parent, and he is the Chief of Organizing, Advocacy, and Learning at Civil Influencers. He is a longtime disability advocate who works to bring issues of inclusion to the forefront of all communities. He has significant experience working at the intersection of disability policy and social needs in both the federal and nonprofit sectors. Mr. Coakley believes that it is imperative that the disability and traditional diversity communities learn to work together as they both share the same core values of inclusion. Patrick?
Thank you so much, Nicole, and thank you everyone for having me today. My name is Patrick Coakley. I am an African-American man whose long locks are pulled behind my head right now. My pronouns are he, his, and I am talking to you from unyielded Lenape territory in Montclair, New Jersey, and it's a pleasure to join all of you today. As I mentioned, as the slide mentions, I am low vision. So whereas I have all sorts of magnifiers and fun things on my side of the screen, you can't see any of those. And as you can imagine, that often makes it difficult for individuals to sort of even note, sort of like the significance of my disability. But I wanted to share a story with y'all about the birth of my first child. My oldest, Jackson, and my wife and I actually have three right now. There's a lovely image of us in our DC home on the screen right now before my third child, my youngest son, Kendrick, was born. But when Jackson was born, we knew that he was going to have achondroplasia. When someone who is average height is normally married to or has a child with someone who has dwarfism, there's sort of about a 50-50 chance of whether or not the child will have dwarfism or whether or not they will be average height, as the LP community normally refers to them. And so we knew that Jackson was going to be a little person right away. But what we didn't expect was that he came a little bit earlier than planned. And because of that, we found ourselves in the NICU. Now, what made this interesting is, of course, the expert on dwarfism is, of course, my wife, who has achondroplasia, and her parents had achondroplasia. So she knows everything, sort of about it, and, can talk, ad nauseum about, the history of achons and ways for there to be accommodations in our society. And I had the pleasure of working in disability, so, disability policy. So disability wasn't new to me. But as usual, when kids are born, we find ourselves, mixed up in all of the unexpected. And the first unexpected piece for us was that Jackson had not passed his meconium plug when he was born. And because of that, the hospital that we were originally located in had to send him away to a neighboring hospital, still in town, but a little bit across town because there was no NICU at the place where we decided to do our birth originally. Everything had gone fine. Except for that meconium plug. Now, this gets exciting because, again, remember, I stated that I'm low vision, so that means I don't drive. My wife is the one who drives. And so what that meant for me was a lot of transportation sort of related headaches as I tried to figure out how I was going to navigate between our house, the hospital where my wife was, and of course the other hospital where Jackson was in the NICU. We ended up getting it together, but I think as everyone here may know, your NICU experience, it's very bare in the way that the NICU itself in some ways is a sort of a bare bones place made for treatment and engagement for the babies to have everything they need. It often can feel like that emotionally. You feel very exposed to everyone around you. We were very fortunate that a lot of the other parents in the NICU that we were with were attempting to provide some basic emotional supports. But a lot of Kristie's story resonates with me as well because you do feel very othered. You feel, in some ways, very much alone and yet at the same time on display. And everything about managing your personal disabilities also comes to bear as you're thinking about how do we make sure that this new person who also has their own disabilities has like the best and the fairest shot, starting from the beginning. Everything went fine. Jackson ended up having an enema, passed his meconium plug, and we started that long process that Kristie also mentioned, where we were trying to wait and wait and wait until he got his level of feeding up to the place where the NICU was willing to release us. And it seemed like it was taking, like there was some foot dragging going on. It seemed like it was taking a little bit longer than it should have. And my wife, who had finally been discharged from the other hospital, we started having conversations about, the difference between babies with dwarfism, understanding that, like the amount of size and the amount of food might be a little bit different. And really trying to impress upon them that, not that we knew what we were doing as much as any young couple, but that we were prepared for all of those pieces. The worst part for me came when we're still attempting to get Jackson discharged, and we're starting to have the round of consults, and they say, okay, we're gonna start these processes. We're just gonna make sure that he does like a consult with all of the folks in the NICU to make sure that everything is okay, and then we can go ahead and get him discharged. And I got pulled aside by the genetics, by one of the doctor handling the genetics consult. And I often shudder. I still think about like what would have happened if I was not prepared. What would have happened if I had not had a background in disability policy, or what if I had not worked in large administrations and understand that people, that there's different processes for how things can get done, and that there's no one final piece. The geneticist pulls me aside and doesn't have this conversation. We're not having this in an office. Literally just sort of steps outside the NICU in a side corridor and says, hey, I want to talk to you about the baby and, make sure that everything's all right. And then the very next question that she says is, well, before we get going, this is gonna, I don't want to insult you. I'd like to know what your level of education is, which for me as a African-American man who's living in Washington, D.C. at the time was very insulting. Don't assume anything about me. And if you're going to ask me my educational level before you tell me something that you're insinuating is important about my child, it seems to me that not only you're insulting me, you're attempting to put one over on me, which indeed she was. She waves a paper in my face and starts talking about the necessary need for study for babies with achondroplasia, about the work that she's done, and insinuates that if I didn't give her permission in order to do some extended examination and study, then it would mean that Jackson would have to stay in the NICU longer. Now, what's terrible about this is, of course, that's not the case. That's not how any of this process works. She was just offering a consult. But what makes it even worse is that for the paper that she waved in front of me, I knew all of the doctors that she was referencing in that paper. My wife had been, like I said, my wife has achondroplasia. Her parents had been involved in some of the first studies at Johns Hopkins, and so we knew a lot of those doctors that the geneticist was referencing personally. On top of that, insinuating or suggesting that if I did not do this thing that she wanted me to do, then somehow that my child would have to stay in the NICU longer is also just terrible. And I can't help but think what would have happened had I not had all the preparations that I had. Had I not worked in healthcare policy and known that she wasn't the final decision maker. Had I not known that I could say no. I think probably the worst part about the experience too was that if she had just asked and said, "Hey, I'm doing work around geneticists and achondroplasia, and I'd love to to learn more or know more," my wife and I probably would have said yes. But instead, she chose to insult me, and then on top of that, insinuate that she was in charge of our care. Now, fortunately, we'd already met. I knew the head of I knew the attending for the NICU. We knew how processes work, but I shudder to think what would happen for less prepared parents who are equally emotionally afraid as I was at that time. And they had run into a situation like that. And they would have found themselves, sort of at, being held almost hostage by this one medical professional who, yes, it may have been for the benefit of study, but was doing something that would ultimately have been detrimental to the mental health and to the engagement of a young family starting out with their first child. So I count myself lucky that I was prepared for that. But I just remember, like Kristie, I remember the rage that I felt. I remember calling my wife because she wasn't at the hospital at the time, and having her talk me down and say, tell me if I'm overreacting, if I've gone too far, if I'm reading this the wrong way. And unfortunately, what I've learned is that this sort of manipulation of the medical model happens far too often, where under the guise of being doubly sure or being certain, individuals with disabilities will find ourselves manipulated, caused to wait longer, or even sort of like directed away from our natural rights as parents and as individuals, as people. And it's one of the things where, again, I think if I'd not been prepared, if I'd not worked in large bureaucracies, if I didn't understand my personal rights as a person, I would have been, directed, and my son and my wife would have had to sort of wait it out with that person and hope that after her study and after the intense genetic, consult, and after all she'd been satisfied, that we would have been able to leave the NICU, rather it being when we had fulfilled what we needed to fill and we were satisfied. So thank you for hearing that story. I'm not totally put off to the NICU. I also want to say that while we were there, I met some of the greatest families and greatest people. It was exciting to be a part of that community and to be able to like support people and say, hey, remember, this isn't the thing that defines you as a parent. But it was certainly not one of the best experiences I've had in my parenting life. And I think about it all the time when I think about how we have to be careful as people with disabilities, how we navigate the the sort of medical complex, a place that's supposed to be supporting us, where at the same time we have to keep another eye on them to make sure that we are not going to be discriminated against because of disability.
Patrick, thank you so much for sharing your story. Equally powerful, and so many things to think about. When we think about implicit bias, it can really show itself in the NICU, and not just implicit bias, but often overt bias, overt discrimination, in addition to the covert sorts of discrimination. We are going to move on to our last speaker. Dr. Paige Church is based in Toronto, Ontario. She is currently an assistant professor at the Department of Pediatrics at the University of Toronto, forgive me. She's currently on staff at Sunnybrook Health Sciences Center as a staff neonatologist and is a consulting developmental behavioral pediatrician at Holland-Bloorville Kids Rehabilitation Hospital. She is the director of the neonatal follow-up clinic at Sunnybrook, and lucky for us in Metro Boston, she is soon to be at Beth Israel Deaconess in their Department of Neonatology. In fact, she just moved. So I'm going to hand it over to you, Paige.
Thank you, Nicole. Thank you, everyone. Just quickly, to give a description, I am a white woman wearing a blue and white top. I have glasses, and I go by my pronouns she and her. And we will go, and I'm trying to go a little bit quickly only because I want to leave time for some important conversation, because I think those first two talks were incredible. So I titled my aspect of this talk, The Failure of Imagination and the Impact of Implicit Bias in the NICU. Next slide, please. Sorry, thank you, Nicole, for advancing my slides. She's my technical wizard. I put this up, just return to sender, just as a quick reminder that often I feel like I am the imposter and I shouldn't really be giving any talk on the experience of individuals with disabilities. To give you a sense, I am a physician, but I'm also an individual who lives with spina bifida. So I do have some insight, but I've never been in the NICU. Next slide, please. Quickly, what I hope we're going to accomplish today, and I think we've heard a lot about it already, is to talk about the trauma that any parent experiences in the NICU. And then I'm going to just quickly go over the historical context of disability and medicine, and then identify areas where disability, where disability and medicine dance together, and then how this infiltrates to the bedside. Next slide. So this is a recent paper that came out during the pandemic, and I think it's a great place to start talking, because really what this is looking at is, this study looked at the presence of implicit bias in society between 2007 and 2016. And they studied many different areas that could have implicit bias, and I only put up the one around sexuality, but there was gender and race as well. And what it shows is that the rate, or the presence of implicit bias in society over time has improved around just about every aspect: race, sexuality, gender, but it has remained very stable, meaning there has been no improvement in the implicit disability attitude around disability. And just quickly, implicit bias infers the presence of a bias that comes out not necessarily with your words, but with your attitudes and your behaviors. And sometimes it's through your words, but it isn't necessarily something that someone is conscious of. Next slide, please. And when you think about how this could have all started, or where this could start from, I think medicine, and we've alluded to this with Patrick already and Kristie, medicine has a hand in this. This is from an old paper from 1979, and it describes what it called rubbish, talking about people. Rubbish in the medical world, and this was in the emergency room, was defined as people that medicine couldn't fix, and I put that in air quotes, or that which an individual couldn't fix, and I put that again in air quotes. So what really medicine sought and enjoyed and really perpetuated was this: they wanted things that they could solve. Things that were, setting a broken bone, plastering, stitching, things that were fixable were much more rewarding to people in medicine. And I think this subliminal message still exists in the medical training even today. Next slide, please. So this, and Patrick already alluded to this, this bias is ableism. And ableism is defined as a network of beliefs, processes, and practices that produces a particular kind of self embody, the corporeal standard, that is projected as the perfect, species typical, and therefore essential and fully human. Disability is then cast as a diminished state. Next slide, please. And this does, that paper that I referred to around the rubbish was from 1979, there are far more recent papers that are sharing the same presence of this bias existing in medicine. This study by Lisa Lizzoni was from 2021, and it looked at over 700 physicians who responded to this survey. Half of them were family medicine, half were subspecialists, including obstetricians and gynecologists. And 82%, so the vast majority, reported disability as being associated with a worse quality of life than those patients who did not have a disability. Despite that, 40% felt that they were still capable of providing the same level of care. Next slide, please. And again, that deep-seated bias is present with healthcare workers. This was a little bit earlier of a paper. This is from 2020. But again, it shows that most of the providers in this sample demonstrated or articulated a strong preference to care for non-disabled people. That's the largest black bar to the far right. And many, many fewer physicians demonstrated, or providers demonstrated, an interest in providing care for people that were non-disabled, or that were disabled. Next slide, please. And just quickly, I think the story goes on, and it's quite similar with every single study I put up, but just to drive it home, this was looking at genetic counselors. And so genetic counselors are people who may interact with a couple before they have a child, and they would be the ones to first share information around the possibility of a disability. And they were able to sample 10% of their whole field. and they used the disability attitudes implicit association test, which I'm not going to get into right now, but it is a very valid and standardized measure to measure this. And what they were able to do is demonstrate that even among genetic counseling counselors, that there was a bias towards ability. So they demonstrated a preference for people who did not have a disability over people who did have a disability. And it wasn't associated with their exposure or experience with individuals who had disabilities. Next slide, please. So this matters at the bedside because of something called microethics. And microethics is really described as every interaction that happens between every doctor and every patient. So instead of it being this broad moment, it's everything we do. It's our mannerisms, it's our language, it's everything we do introduces the possibility of bias. And so if you think about it, the vernacular in medicine is laden with ableism. I mean, just think of the words: risk, severe, poor neurodevelopmental outcome. Those are just a few of the words commonly used in neonatology. Next slide, please. And this matters because as humans take in language and process it, and this is called relational frame theory, we have an innate ability to form associations between concepts. And those associations are bidirectional and unintentional. And it is this way that the brain learns. That's how we learn how to speak, and we learn language, and also literacy. It is also theorized to be associated with psychopathology. Next slide, please. But when you think of the words commonly used in the medical literature, how is it not possible to put an association together? So it is impossible, I should say, to not associate disability with something negative. And I feel like I'm using so many double negatives. If I use the word risk and cerebral palsy, how is it possible that cerebral palsy is anything other than a negative attribute? Because risk infers something negative. I don't have the risk of winning the lottery. I have the risk of a thunderstorm. I have the risk of a car accident. It is something that may happen that is negative. Instead of, and severe, there isn't really a possible positive word that goes with severe. You don't have a severe, dress. It's beautiful, or it's something, but it's severe is a sunburn. Next slide, please. And these biases are laden in our literature that we share with the world about neonatology. This is from an editorial that we just published last week through the Lancet, so I couldn't put up the thing because I handed these slides in about a month ago. But in our outcome literature that we present for over the last 50 years, we have had it filled with the idea of a framing bias, where we put forward that death and neurodevelopmental impairment are the same outcome. So when we do our research, we will look at how babies do, and we'll bundle the two outcomes together to get statistical power. But how can you possibly say that death and neurodevelopmental impairment are the same? They're not. But when you put them forward as that, you share with the medical world and the healthcare world that they are similar outcomes. And then even if we just splice out neurodevelopmental impairment, they always associate mild, moderate, and severe. Well, that's to who? To medicine or to the people living with it? I think that is equally insulting. And then the other bias in our outcome literature that we're very guilty of is something called the ambiguity aversion bias. We don't like to have outcomes that are not specific. We don't like the unknown. So instead it becomes, you have a dichotomous yes or no outcome. You either have a neurodevelopmental impairment or you do not. And then we put forward that these impairments are cerebral palsy, cognitive, hearing, and vision impairment, but these are arbitrarily set by healthcare providers and not by parents. Next slide, please. And the problem with this is that this implicit bias becomes practice. This is from Annie Janvier, who I love, from Montreal. And she did a study where she interviewed providers in the emergency room, and she provided a variety of possible scenarios that would come into the emergency room and require resuscitation and intubation. And you can see that the least likely person to be resuscitated was an 80-year-old man with metastatic cancer. But the second least likely human to be resuscitated was a 24-week baby And her theory and her feeling was that this was because of the association that 24 weeks has with disability. Next slide, please. And so it is into this emotional cauldron, as John Lantos called it, of the NICU that any parent enters. And I love this spaghetti diagram from Virginia McLaughlin, who was a nurse at Sunnybrook. She just drew all of the different ways that trauma can come into the ICU. And this quote from Michael Heinen: "Distress is the companion of everyone in the NICU." But you can see that the trauma is exposure to judgment. Well, we see a lot of that. Pre-existing challenges, fatigue, the lack of control, living with the fear for your baby, fear for your abilities, everything, isolation, identity crisis. This isn't where you thought you were going to be. So there is exponential trauma for parents. And then on top of that, amplified on top of that, is the experience, I think, of individuals who have a disability entering into the NICU as parents. Next slide, please. And so this gets to a topic that was, I couldn't find any evidence around parents in the NICU. There are not any papers that I know of. So I went looking instead for experiences of disabled women going through having a child in the ICU. And what we found was that that the pregnancy, when they talked about their pre-pregnancy and then their peripartum and then their post-pregnancy, about a third of them reported feeling that their dignity was not respected. And the quote I wrote down was, "I felt that the staff were annoyed by my requests and that they behaved as if my physical limitations were an inconvenience." Or another one, "I was treated as though I was being dramatic. The communication was poor. All of my options, if there were any, were not explained." And these are just women who go in and deliver a baby, not women who experience the NICU. Next slide, please. And this gets, oh yeah, sorry, there are the quotes. Next slide, please, sorry. And so really what this is that I love this photograph. This is a photograph of Fenway Park. See, I'm getting ready to move back to Boston. What I read about implicit bias is it's a social phenomenon that passes through individuals like the wave passes through fans in a stadium. Rather than a property of individuals, it may be more properly considered a property of social context. And so it is in this environment, not Fenway, but the ICU, that our families who have disability enter the ICU. Next slide, please. So this gets to the title of my talk, which is that discrimination results when people in one group fail to imagine that people in some other group, regardless of what that other is, lead lives that are as rich and complex as their own. Everyone from literary theorists to bioethicists to obstetricians are susceptible to such failures of imagination. Next slide, please. So my takeaway messages, and hopefully I left enough time because I think there's such important discussion, is that ableism exists in society and in medicine, that the NICU has demonstrated historically ableism in both its research and its care, and that care affects both the infant and the parent, and that the consequences of this ableism are life and death for our NICU patients, but family altering and further traumatizing for a disabled parent. Next slide, please. So thank you very much. That is my daughter with one of my children, the dog, and that's my email.
Paige, thank you so much for providing that perspective. I think one thing that is really interesting is, some of us who are parents with disabilities, we're at that nexus of having been disabled kids and might have possibly had NICU stays ourselves, and then circling back around to the NICU, this environment that disability is very, very much at the forefront of everybody's mind in the NICU. And when you circle back around as a disabled parent, well, it's hard for any parent that's there. It can be especially charged for disabled parents. This is a little blurb about our National Research Center on Parents with Disabilities. We're a cross-disability initiative guided by the ethos of the disability community. Nothing about us without us. And at the end of this deck, there will be our website. So please visit our website. We have lots of materials there. We have materials for providers. We have materials for legal professionals, for social workers, for parents with disabilities, and for the family members that love those parents with disabilities. Okay, we'll open it up to questions. I'm going to stop sharing my screen. And we'll put questions here. So the first question, Kristie, it's for you. My question for Kristie is, why allow the staff to speak to you in a derogatory manner? I feel that as a disability advocate and invisible disability haver myself, that we have to change the narrative with regard to our abilities. Everything is a teaching moment. We cannot let others cower us. I understand the fear that you have, but I want you to know that you are fantastic and capable. So, Kristie, what were some of the stressors you felt, and why did you maybe not feel as comfortable as you would have in other situations to speak up?
I mean, it's a complex thing. I do feel that I spoke up, and you have to understand, I don't know if the question asker has had experience with NICU or much hospital environment, but in the NICU, you're constantly dealing with different people all day. Even within the same hour, you might end up talking to 5 different nurses and other staff if it's busy enough. And so I was saying the same things over and over again. I am capable. I know how to do these things. I need Stephen's help here more, but at home it's not like this. At home I do it myself. So I was speaking up for myself, and also they weren't looking me in the eye and saying, oh, you're not a good mother. You can't take care of this baby. They were saying, oh, of course you can do it. We just want you to be successful. Yeah. But there was just this feeling of, like something, the nurse that I mentioned, with whenever I would breastfeed, she was very fretful. And she would say, I'm just not sure that that's nutritive sucking. I would say, I feel the tugging. I see the milk in her mouth. I hear the swallowing. And she would say, no, I really don't think she got any milk. I think we should give her the whole gavage, which is how they feed babies through a tube. So it was things like that. That's not easy to speak up against assertively, especially when they did have medical knowledge that I did not.
Thank you, Kristie. I just want to add one other thing, is that the NICU is full of mandated reporters, and
yes.
And mandated reporters, obviously we need to have mandated reporting. However, going back to the blurb I mentioned about child welfare, disabled parents are terrified that someone is going to call their state child welfare agency on them. This seems to be a universal fear among all of us, because we have evidence that shows that people make spurious claims about our abilities to parent, and we end up interfacing with the system in the absence of abuse or neglect, just because we have a disability. So we're very aware of not wanting to be labeled as difficult. You know, we want to work within the system, and sometimes so we can get out with our families intact. Next question for the panelists: are there examples of hospitals or clinics that provide sensory rooms or stress reduction resources for neurodivergent parents or babies in the NICU? Do either of the panelists want to chime in about that, or I can take it?
I'm going to let you take it, Nicole. I don't know of any hospitals that are doing that.
I don't either, and I didn't realize my camera was off, sorry. I don't either, and one thing I'll add is that is something we could do. It would really improve the experience for all parents who find themselves in the NICU. I think the experience is so sensory overwhelming, and especially for folks who have neurodivergence, it can be really a really insulting place, just physically kind of insulting on your body. And I think that would be a wonderful addition.
Nicole, can I just add one thing to Kristie's response to?
Yeah.
I see just some of the chat. You know, I haven't been a parent in the ICU, but I have been a patient in the hospital and in the ICU. And I think for anyone who's entering the healthcare system, not as a provider, there's a feeling of powerlessness and a little bit of a power differential. If you're obnoxious, if you're viewed as a pain, you're worried, is your nurse going to take the same care of you? Are they going to be nice to you? That constant sort of power differential, regardless of how you enter, is present. And you know, it is hard. People are being judged. You're being judged for how you behave. How do you behave under stress? My husband was deemed difficult because he asked too many questions. Like, and all of a sudden the care we got was different, you know? So you just want to be the good patient and get the hell out without someone really making your life more difficult, I think. And then you add that layer of being the parent, I think it's huge.
Yeah, indeed. This is Patrick. I think it's also worth stating too that like the NICU doesn't look like it does on TV or in movies, as well. And so if any of y'all are picturing like this sun-soaked, you know, room full of like clear bassinets and, you know, like, you know, motherly women tending to the children there, no, the one we were at Georgetown, it's in a basement. It's poorly lit. It has a very industrial medical vibe to it. Yes, there are rocking chairs that you can bring in, but like it's you don't in a NICU as a parent, it is not easy to feel like you belong there. Because especially if they are doing what they're supposed, the medical professionals doing what they're supposed to be doing, it is largely about care, and they want you as a parent to be there. They know that's important, but that's not the vibe. The vibe is not one of come in and sit and let your energy spread through this place. And so I think there is something to be said for how we can continue to make those places more accessible. I'm intrigued by the concept of what we do, especially as we consider more parents who are on the spectrum or more neurodiverse, or as we start making parents with very visible disabilities more of a norm. How do we make those spaces more accessible as well?
Next question, we might have time for two more. Kristie and Patrick, was there any follow-up home care visits offered to support you in the first few weeks of discharge?
For
Kristie?
me, sort of. We are in a very rural area, so 2 hours from the NICU, I'm talking like over a mountain pass. And we do have a hospital, but they don't have anyone that specializes in like obstetrics or anything of that nature. They had some home health nurses come and weigh my daughter a few times, but that was about it.
We very much, I don't believe they offered, we also very much gave them the brush off, because, you know, like I mentioned, we already had our friends set up for the dwarfism clinic at Johns Hopkins. We sort of had everything planned already. We were just trying to get out of the NICU. So thankfully, we didn't have any follow-up pieces.
Yeah, and one thing I'll say to that is it takes an incredible amount of bravery to let someone in your house when you have a disability. And if you can establish trust, early intervention can be fantastic with trust established. And with that, we need to end. I want to thank our panelists for all your wonderful input and everyone for your wonderful questions. Thank you so much. And we will be providing a survey via email for you, and also for CEUs as well, the post-test. Thanks again.